You know how to diagnose and treat patients, but the billing system that's supposed to compensate you just oftentimes feels like this huge black box. So the good news is you don't need to be a certified coder to have a massive impact on your practice's revenue, but you do need to understand a few key triggers to make sure that you are getting paid what you deserve. Today, we're going to walk through 10 high-yield billing rules, or just concepts to make sure that you are matching both the clinical perspective as well as the coding side of things, so that you do capture these little codes, some that can pay out big time and some that can add just a little bit of revenue, but over time adds up to a lot. So we're going to talk about the top 10 things that we've been seeing in our practices while we've been doing the coding or the scrubbing or the claims review for practices that we do that for. So before we dive in, a quick question. Is your practice even set up for success to bill out any of these codes? Many aren't, and so that's why we've created an eligibility toolkit for you to be able to use to train your staff. It is detailed. It is everything you need to be able to put a eligibility process in place. And if you are looking for some additional help related to policies and procedures, just education around the billing team, we do have our new school course that is coming out here in the next few weeks. Head on over to natrevmd.com and just go to resources billing course, and you can see the different kind of billing course options. We have some with our legacy videos, and then our 2 new tiers, which will have policies and procedures, everything you need to put into place. Obviously, if you are a client, you get all of this for free. But if you aren't a client and want to check those out, again, head on over to our website, go to resources and billing course, and you'll see our school link to go check it out. All right, so let's get started. Rule number 1. So again, we're going over kind of 10 different rules for you to think about to make sure that you're coding appropriately when it comes to coding in your office. So a lot of these are outpatient examples that you can use to make sure that you are coding enough to get paid what you deserve. All right, so the first one is just around prescription drug management, right? So you've evaluated a patient, you've determined that they need a new prescription or a change in a prescription that requires obviously monitoring because you're putting them on a drug. So you'll just want to make sure that you are really evaluating if you can bill a level 4 or a level over a level 3 E&M visit, because per the 2021 E&M guidelines, right, the decision to start prescription drug kind of falls under that moderate level. And with regards to the risk for MDM evaluation. So moderate level of MDM is one of the primary requirements for a 99214. Now, obviously, it's not automatic. There are things, there are multiple MDM categories that you want to take a look at. This is just one of the 3, but you do want to make sure that you are taking this into account. So obviously, you need to document that you're changing or doing something with the medication. And so that's got to be part of your documentation. And then you can evaluate if you can code for that. So we have seen a lot of folks kind of being safe, billing that 99213 when there are multiple things that are going on with the visit, including drug prescription management, that then would kind of bump that into a 99214. So take a look at those coding guidelines and make sure that you and your office understand. Again, if you haven't had a coding audit in a while, this is a great way to do a coding audit and have this kind of be one of the things you evaluate. Are you billing enough of 99214s? Are you overcoding, undercoding, et cetera? All right. Rule number 2 to take a look at is injection visits. So obviously you've administered some sort of injection, steroid, antibiotic, et cetera, and you want to make sure that you are actually billing for all 3 components separately. So obviously the administration, the drug itself, the J-code, and then the correct number of units. So those are the 3 things that you're going to want to double check and make sure that you have right, that the billing team has right, et cetera. So obviously the administration code pays for the staff's time and skill of actually giving the injection, whereas the J-code is actually reimbursing you for the cost of the drug itself. And want to make sure that you have the units correct so that you're getting paid. Obviously, waste and other nuances around injections is important as well. Obviously, you must document this within the notes, the exact dosage, the route of administration, the location of the injection. Any waste or discarded units also should be documented. Another common mistake is just that the NDC codes aren't added on, or there's a denial for those. The billing team doesn't know how to get them. They ask the office for them. The office, may respond to an email, but it's just like the email chain that never gets answered. So that's why I'm a big proponent that we get these listed out kind of in an issue tracker or something so that stuff doesn't get lost in an email. All right, so rule number 3, modifier 25. Oh, this is a big one. So you really want to make sure that you're not under or overutilizing modifier 25. So common scenario, we see patient presents with a problem that requires a significant and separate evaluation. This is key during a same visit as, say, you either perform a procedure or even do a wellness exam, and you either don't add the modifier 25, or alternatively you add a modifier 25, but the E&M visit or the procedure is not truly separate and significantly identifiable. And so really want to make sure that you understand this rule, when to apply it to your E&M code, when to apply it for your procedures that you're doing, so that you get paid separately for those. As you guys all know, the modifier 25 really tells the story. Again, it's appended to that E&M CPT code, and without it, payers' automated system are going to bundle those services within the procedure or the wellness visit, etc. And so you'll just want to make sure that those are called out. You'll also want to make sure that your documentation clearly shows the medical necessity for the E&M visit, which has to be completely separate from the procedure or completely separate from, obviously, a wellness visit. And so you'll want to make sure that you document almost like a mini evaluation and plan of action for the separate reason that you are calling this out, right? So that's really, really important. All right, rule number 4, vaccine administration with counseling. This is another common one that we see folks forgetting to add on these CPTs. So obviously, if you're administering vaccines to a patient under 18, you're having a discussion about the vaccine to a parent or guardian. And so you can use that 90460 as for the first component and the 90461 for each additional component. So codes specifically for vaccine administration includes physician or other qualified, healthcare professional counseling, and are important for you to add on for additional revenue. Want to make sure that you are, obviously documenting that you gave the vaccines, that you discussed the risk and benefits of XYZ vaccine with the mother, who verbalized understanding, yada, yada. So again, just really want to make sure you document and that you're billing for these. Important rule number 5 is just making sure that when you are doing procedure visits and the patient's presenting specifically for that, a simple planned procedure, and whether that's earwax removal, dressing change, but no other problems are addressed, you'll want to make sure that you are not billing also for an E&M for that. So kind of the opposite of the modifier 25. Again, you'll just want to make sure that when you are billing for a procedure, that you're not adding on an E&M unless it's, again, separate and significantly identifiable. So you'll just want to make sure that you're thinking about that. All right, rule number 6, high acuity visits. So patient presenting with high-risk problems such as acute shortness of breath, with hypoxia, chest pain, with EKG changes, or severe infection with systemic symptoms. And systemic symptoms is a good thing for you to kind of just think in your mind and trigger. So that acuity is almost always going to justify a level 4 or level 5 E&M. And so you'll just kind of want to, again, review that MDM table, really think about risk and how this condition potentially poses a threat to their life. And so that's where you're really going to be able to help identify, is this a moderate or high level of risk to be able to qualify for those higher level codes. Really, really suggest don't let audit fear cause you to undercode for these complex stakes or complex high stakes cases that you're working through. So you do want to make sure that you're documenting a clear picture of the severity. You're talking about the vital signs. You're talking about the systemic symptoms that are going on, that you have a differential diagnosis, a potential for decompensation, et cetera, so that you can really, qualify that, hey, a patient is here for moderate, respiratory distress, concern for PE versus severe pneumonia, etc., and then show those vital signs, that's going to be able to help, qualify for that level, for level 5 E&M code. All right, so rule number 7, data points. So as part of all of this, right, you're ordering tests, you're reviewing labs or imaging or consult notes from someone else. You want to make sure that you're adding all of these data points to your note, because as you know, the MDM table talks about amount or complexity of data, which helps again support that level 4 or level 5 visit. So E&M guidelines, there's many tables that are out there that help you kind of qualify visits. If you have physicians who are struggling with this, you could print those out and have them in the exam rooms, or have them be able to kind of check some off if they're trying to get that into the habit. Or again, doing coding audit with some education so that you really make sure that these are understood. All right, rule number 8 that we're seeing is just making sure that you're adding that venipuncture. So your staff draws a patient's blood in the office. You can add that 36415. Obviously, this is a code for the technical service. It's not bundled into an E&M visit. Payment can be billed separately, even if you're not billing out the laboratories, or when you're not billing out the laboratories. All right, rule number 9, drug units. We sort of talked about this earlier, but just want to really call this out, that in clinical scenarios where you're billing for an injectable drug, you want to make sure that the number of units, the dose administered, is all outlined. And so each J code has specific unit definitions that you want to make sure you or your team know. So it just depends on the drug. And so you bill based on the volume injected instead of the dose. And so you'll want to make sure that you have these unit classifications spelled out for your team. And so your EMR, your billing system, can configure you to do this conversion correctly depending on the drug. And again, just really make sure that you have this noted in the documentation of the note as well, so that you can combat any denials that come through or medical record requests. All right, rule number 10. This is another one where we're just seeing that you want to make sure that when you're finalizing your codes for a visit, that every CPT code on the claim must actually link to an ICD-10 code, which establishes medical necessity. Softwares should catch this. It's a fundamental logic of the software to make sure that clean claims get through, depending on your software. But again, just want to make sure that those linkage rules are right, and that your team understands, the order of those linkage rules to get that CPT code linked to the right ICD-10 code in the right order, so that you don't have claims that are denied. Again, most software will kick it back to the billing team if there are issues with that, so that they can add a CPT code, add an ICD-10 code, or move the order of those around. All right, so these are just the little things that our team has been catching for some of the practices that we do coding for. And again, it's just easy, quick tips that you want to make sure that the team is following. Again, for most practices, coding is done by the physicians, but in a rare few cases, our team actually does the coding. And so just want to master these rules, make sure that you're compensated fairly. All right, hopefully you guys enjoyed this episode. If you do, we would love it for you to share this podcast with a friend or a colleague. It helps us impact the lives of other physicians. All right, have a great rest of your day.